We are playing outside. We were
Playing
so
outside.
hungry. After I have to rush to eat.
They hungry?
Yeah.
Okay, mom is there.
Yeah.
Oh, they are playing. They are so cute. And they are quiet. Okay, hey Sin, how are you? Hey Lori. It looks like you need time to have everyone.
Are we
I'm
doing
gonna
cardio today, Dr. Manal?
we're done cardio.
Oh, we're done. Oh, okay. Sorry. I'm just making
We
sure.
last time we are
Oh, yes.
done
Yes, we're done with
with
cardio.
cardio, neuro, um,
GI.
GI, many things actually.
Okay.
Today we will start infection
Nephro.
control.
Oh, okay.
We'll do endocrine,
Okay.
very important endocrine. We need to make sure we're good in that, and musculoskeletal. And then if we still have energy, we can do maternity peds.
Did we
Summary.
do renal?
We will do renal.
Okay. Thank you.
Passcode. Justine, it says passcode. Is she here, Justine? Hey,
Oh, it's because
Chanel.
we don't have access anymore with our
Hi, Dr. Mel.
with
Hi.
Concord stuff, so we have to log in with our own.
Yes. Okay, let me find if I can find a passcode for this meeting.
Hi, Dr. Manal.
Hi. Who said hi?
I did, Liz.
Liz. Hey, how are you?
I'm doing good, not so bad.
Ready for tomorrow?
Breathing. A little nervous,
Yes.
but yes, I'm ready.
It will be great. It will be great. It will be easy. I will check on you. I'll give you a
Yes,
call.
ma'am. Yes, ma'am.
There is a passcode. I'm sending it. Okay. I sent the passcode for whoever cannot get in. Go. Brittany, Carolina, Katie. Hello again. Hey, Annette, how are you? I want to say you saying hi back so I know that you're here. Hey, Annette, how are you
I'm
doing?
good.
Good, good, good. Was
Hi,
pleasure
Dr. Manal.
seeing you yesterday. Hi, Brittany, how are you? Great seeing you
Good, and you?
yesterday. Carolina, hey, I didn't see you yesterday, Carolina. Did you came late?
Yeah, I came late.
My bad luck. But did you enjoy it?
I did. I felt
Yeah.
very busy yesterday.
Yes, yes, absolutely. And Chanel, hi, good to see you. Elizabeth,
Hi, Dr. Manal.
again. Gianni, again. Katie, how are you after yesterday? Still happy, excited?
Hello. Yeah, very much so.
Hello.
It's excited.
Very, this is pleasing. Melissa, hey, how are you, my dear? You were so cute yesterday. We need the pictures with your professional camera. You have them ready?
Mhm.
Melissa, you have the pictures ready for us. Whenever you have them, send them. Okay. Raiden, Roxy, Sen, Zach. Hey, Zach, how are I didn't see you, Zach, yesterday. Did you come late? Huh, looks like it. Did you come late, Zach, yesterday? Jocelyn, hey, how are you today? You didn't go. Okay, okay. You missed it, and we missed you. Okay. Hello, everyone. So today, let's make it also a very good session to review. Last time we spent literally 6 hours of very focused review on many topics. Let's make it happen today. Today will not be 6 hours for sure. It is late. Let's see what we will do in 4 hours. And I will appreciate more cameras on because I want to see live people. Yes. Roxy, Katie, you're always making me happy. Hopefully you'll have everyone have the camera on if possible. Okay. Number one, I want to update you guys that we checked today the registrar. Thank you, Caro. The registrar deemed you as graduate. So when we checked your status today, we found you like school documented that you're graduate. So now our school can pull your record of nursing RONP. No problem, Gianni. So now the school will have your RONP can be sent to the board. There was a little delay. The reason is some of the students, they have not completed their hours. They need to do some makeup. It usually happens faster, but some students from both terms, weekend and weekdays, they weren't done with their makeup. So that's why the registrar just today deemed you as grad. So you're all grad officially, and the school working on the RONP to be sent to the board. Once it is sent, I will send you an email with step by step how to apply to the board. I'm gonna attach your live scan to the email because you will need to upload your live scan to the application. Okay? Once you apply, you will send Miss Linda your username and password for your Breeze account, and she will process the payment. It is always good to CC me in this email so I can track who already ready to be paid for, so I can follow up with her. Is this done? Not done? So instead of being like, did we finish the payment? I will say, Roxy payment is done. Caro payment is done, Raiden payment is done, so I will be able to follow up with each one's payment. So CC me in the email where you send Miss Linda the username and password for your Breeze account. Once payment is done, we will be waiting for the board to reply. It takes 2 to 3 weeks. While we're waiting, we will be working together, either to like take some diagnostics, or I already have people finished 2 diagnostics, passed 2 diagnostics. They have 1 left. So this is how fast it could be. And then we will have remote follow-up on your studying until you get to hear from the board. What will happen when you hear from the board? What will happen?
We will
We should-
scream and we will cry.
You'll say
You
you
will hear
passed.
from, no, you what? When you hear from the board will tell you you're eligible. Roxy, you are eligible to schedule a test date. This is via email, guys. So you will come to me and I will register you on another website. Hopefully everyone is hearing me because I said that before and we still get questions on them. So when you hear from the board will tell you you're eligible to schedule a test date. Now this is my role. I will register you for another website called Pearson VUE, and I will put you a test date. We will pay for that. And the same day, like as we're talking, as we're putting you a test date, payment will be done right away, and you will have a test date. And you will have day-by-day study plan until your test date. So it's not only one application, guys. One application to the board, you will send that. Okay? Once you hear from the board, you will meet with me one-on-one. we will do another application to another website, and we will schedule you a test date same day. Yes, but you will not test the same day. We will talk about when are you going to test. If you're ready, sometimes I send the people the following day, tomorrow, go. Or we can wait a week or 2 weeks. It depends on everyone's readiness. So questions. Questions. You're aware of the process, how it will work? Yeah?
Yes.
This after your greenlit. I have 20 out of 22 greenlit from the weekdays. Good job, guys. And I have 10 out of 22 some. How many are you guys, weekenders?
I think we're like 18.
18. So just come more. So I have, I believe, 10 greenlit. So I wanted the rest to be greenlit. So we will send your application very soon. Any questions? Is it clear? If clear, give me thumbs up or thumbs down. I will take the thumbs down. Okay. Okay, guys. Whenever I have you to take exams, there is certain area I always see people like have low performance in. There is certain area I want to visit today, and I want to start with. It is infection control. This is so high yield. NCLEX guys like to ask you about the infection control. NCLEX want to make sure you will not cause infection. NCLEX want to make sure that you know how to wear appropriate PPE for each type of patient. So let's review infection control and how the question will be asked on infection control. So this will be the first part of our review today. After that, we will hit endocrine. And also endocrine is one of the areas comes second low, one of the like commonly come as low performance. So I will hit infection control. I will hit endocrine, first two topics, and then we will go renal, maternity peds, and we will see how the time will help us today. Today we will have 4 hours together. Okay, are we ready, beautiful future nurses?
Yes.
Are we ready? Okay.
Yes, ma'am.
I'm so excited for you guys. Today is the last online meeting. Remember how many times we met throughout term 5? Woo, we met many times every week. Oh, mental health exam, delegation, management, exit 2, maternity midterm, maternity final, quiz 1, quiz 2, quiz 3, exam 1, exam 2, exam 3, 1350, 1150. Remember all these? So today is the last online meeting. Okay, we for sure we may meet one-on-one later, but it is really, I'm so excited to see you at this finish line. You are at the finish line. You worked so hard to get to this point. I'm so proud of everyone here. You cannot, guys, see how I feel, or you imagine how I feel proud, proud of each one of you. So let's start our first topic in our last meeting. And I'm going to record this. Here, everyone is agree on recording? Yeah?
Yes.
Yes, start recording.
Yes.
Confirm. Okay, thank you for confirming that we are recording. So let's start by this slide, which you guys, you all have in your final lab packet. It is just one page of infection control precaution table, but it is full of information. We need to be aware of every single disease in here. So let me first explain what is in this table. And you all have access to this table. So number one for the infection control, how the question will be asked. Number one question is they will give you client with certain disease, like as example, impetigo. Client diagnosed with impetigo, or they might say a client has yellow honey crust. Yellow honey crust without saying impetigo, because impetigo is yellow honey crust around mouth and nose. What PPE the VN will advise the UAP to wear while giving care for the client? What PPE?
Gown
To
and
know,
gloves.
yes, Roxy. To know the PPE, we need to know what isolation precaution we need to put this patient. This patient, impetigo, means contact. So contact isolation precaution is gloves and gown. So here we have all types of isolation precautions. You have the standard, you have the neutropenic, you have the contact, you have droplets, you have airborne, and you have the PPE. See here it says personal protective equipment. You have the PPE for each kind of isolation precaution. So impetigo is gloves and gown. Okay. If you have client with hepatitis, guys, there are types of hepatitis. There is hepatitis A, B, C, D, and E. Patient diagnosed with hepatitis A. What kind of isolation precaution?
Gowns and gloves.
Yes. Is all hepatitis gown and gloves? Yes.
No, some aren't just gloves.
Some are just gloves because they standard. Yes. So very good. So what first question is what kind of PPE? So you need to know what PPE for each client. Second question, in isolation precaution, they might ask about which patient you cohort with which patient. Like if I have patient with peptic ulcer, and I have many patients, which one I will take or I cohort with peptic ulcer? Number one, you have patient with HIV. Second patient, TB. Third patient, meningitis. Number four, MRSA. Which one I will take with patient with peptic ulcer? HIV or TB or meningitis or MRSA?
HIV.
Why chose HIV? Very good. Why chose HIV?
Because it's standard precaution.
It's a standard. So you look what isolation precaution is peptic ulcer. Peptic ulcer is a standard. And cohorting, it says we can have standard to standard. HIV is also a standard. Okay, so very good. So this is a second type of question here you might get on isolation precaution. So you have these types of isolation precautions. You have the standard. A standard like any mid-surge patient like diabetes, cardiac, COPD, peptic ulcer, hernia, hepatitis B and C, thyroid, endocrine disorder, they are not contagious. Even STI, sexually transmitted infection, they are still standard because the question doesn't say if there is active lesion. If there is STI, but there is no active lesion, this means it is a standard. But if they say there is active lesion like herpes simplex but no active lesion. This is a standard. I will have my gloves on. But if it says herpes simplex with active blisters or vesicles, now it will not be standard. It will be what? If there is active lesion, we will transfer the STI to where? What do you think? It
Would
will not be,
contact?
it will be contact. Yes, because you don't want to touch these active lesions, right? Okay. Then the second isolation precaution is neutropenic. Neutropenic, what the word neutropenia means? What this word means? Neutropenia. Yes. Are you going on the chat here, guys? Neutropenia. What neutropenia means? The end of the word penia means what? This part of the word penia means
Without.
almost very close.
Is it low?
There is. It's not completely without. It is, yes?
No.
Low. Very good. It is low. So neutropenia means low platelets. Low platelets. Sorry, low white blood cell. Low white blood cells. Neutro is a neutrophil. Neutrophil is a white blood cells, is a type of white blood cells. So neutropenia is low white blood cells. Okay, so what? If your patient has neutropenia, means low white blood cell, this patient at risk of what? Low white blood cell.
Infection?
Put your patient risk of
Infection.
infection. Very good. Risk of infection. So neutropenic isolation precaution means this is a group of patients, they have risk of infection. They are fragile. So you wanna not to wear your gloves or your PPE to protect yourself from them. You're wearing your PPE with the neutropenic to protect them from you might transmit any infection because they are so fragile. So it is called reverse isolation precaution. Reverse means you're not wearing your PPE to protect yourself, you're protecting your patients because they have low white blood cell count, they have very high risk of infection. They might frankly say neutropenia, or they might say pancytopenia. What is this? Sometimes they want to be a little bit more aggressive with us. They give you word like pancytopenia. We said penia is low count, right? What is pancytopenia? Okay. Any idea?
Multiple low counts of multiple blood cells.
Good job, Jocelyn. Pan means collectively low count of many blood cells, like could be the neutrophil, could be the platelets, could be the red blood cells. What disease, guys, they have the pancytopenia? What disease could have everything low? White blood cell is low, platelet is low.
AIDS.
Which? HIV, yes. AIDS, yes, specifically AIDS, yes. What else? What cancer?
Leukemia.
Close.
Lymphoma?
Leukemia is cancer in the white blood cell, Jocelyn, right? So the white blood cell will be high, but the red blood cell and the platelets will go low, but you're close. So what blood cancer cause all the white blood cells, red blood cells, platelets will be low? It's pancytopenia. Everything is low. All the blood cells are low count. Yep.
Lymphoma?
Bone
Raise your
cancer?
voice. Bone marrow cancer, you said? Yes. Yes, like aplastic anemia. Cancer in the bone marrow, aplastic anemia, that will cause pancytopenia. So aplastic anemia is yes. Bone cancer like multiple myeloma is yes. It is all pancytopenia. It is all decrease in the count. Leukemia, we have increase in the white blood cell, the cancerous white blood cell, the bad white blood cells. It increased, but it is still non-functioning. So leukemia has high white blood cell, but still risk of infection because the white blood cell is not working. They are cancerous ones. And there is decrease in the red blood cell count and the platelet count. So this is neutropenic patient. You need to put your surgical mask on. Yep. Then contact. Contact, it will be skin diseases like impetigo, cellulitis, pediculosis. What is pediculosis, guys? Pediculosis. Lice, exactly, lice. Scabies, hepatitis A and E, like GI infection like C. diff, E. coli, Shigella, Salmonella, rotavirus, respiratory syncytial virus, MRSA, conjunctivitis. Okay, let's get a hint on each. Impetigo, guys. What is a characteristic lesion in impetigo?
The honey crust. around
Honey
the mouth.
crust, yes, around the mouth, around the nose. Okay, impetigo, guys, is it bacterial or viral? So bacterial, should we give antibiotic? Or is it viral? We select to take or to give antiviral. Yeah, bacterial or viral?
Bacteria?
It is bacterial. Very good. So we need antibacterial. And the treatment for the, what is the treatment for impetigo, guys? What is the treatment? Anybody remember the name of the topical treatment? Hmm? You guys? Yeah, anybody on the chat? Okay, so let's put the name here.
Is it clotrimazole or no?
Clotrimazole. Not this, it is the, here you go. Let me write it for the impetigo. The name of the medication is mupirocin. Mupirocin cream. This is topical antibiotic cream. Topical ointment. And it helps with impetigo. And this is contact isolation precautions. Okay. Treatment of pediculosis, guys, treatment of scabies. Same name of the medication, but pediculosis is shampoo. The scabies is lotion. So anybody recall the name of the medication to treat pediculosis or scabies? Yep. Huh? Anybody? Okay, it is ectomethrin. The methrin, anything with methrin, like ectomethrin. The methrin is the suffix at the end. Ectomethrin. For pediculosis, it is shampoo. For scabies, it is lotion. How long we leave it on the patient? For the shampoo, for pediculosis, leave it for 10 minutes, then rinse. For scabies, the ectomethrin lotion, leave it for 10 hours or overnight, then wash it. Yes? So one name of the medication, just ectomethrin, the methrin, or permethrin. Okay?
Okay.
Then, hepatitis A. Do we have vaccine for hepatitis A?
No.
No. Okay. How to prevent hepatitis A?
Wash your hands after you go to the restroom.
Yes, great. Hand washing is very important. Before you eat, After bathroom. Good job, Noemi. You got the permethrin. Yes, Drea. Can we have caption on? Yes, absolutely. I will add caption. So, but again, I will ask the same question again. Do we have vaccine for hepatitis A?
No.
No.
You guys, do we
Good,
have
yeah.
vaccine for hepatitis A?
Oh, I'm sorry. Yes.
It is
Yes, we
yes.
do.
Oh,
We
sorry.
do.
Not for hepatitis C.
Good job. Not for hepatitis C. Perfect. So we have for hepatitis A, we have for hepatitis B, but there's no vaccine for hepatitis C. Okay?
Mm.
So there is vaccine for hepatitis A. We usually give it for people traveling to endemic area. It is one shot, first one, and there is a booster dose. Hepatitis B is 3 dosages, like first and then 2 booster dose for hepatitis B. So we have vaccine for hepatitis A. Yeah. Which of the following, guys, which one of the contact isolation precaution you see right now, which one you expect there was a history of 3-4 weeks of antibiotic? Which one of these start after the patient use antibiotic for long period? Which one of these
C. diff.
disease? C. diff, Clostridium difficile. This is gastrointestinal infection. Patient has foul odor, bloody diarrhea. This is after long use of antibiotic, because the antibiotic long use will kill the good bacteria, so the bad bacteria will grow and infect the intestine. Very good. Then droplets isolation precaution is, I put this mnemonic, PIMPS H, like pneumonia, P for pneumonia, I for influenza, mumps, meningitis, pertussis, scarlet fever, pharyngitis, adenovirus, which is eye, nose, and the throat, German measles, which is rubella, erythema infectiosum, which is slap cheek or Fifth's disease. Okay, so every single disease here is important. You want to do droplet means put your surgical mask on in your PPE. Then, which one of these diseases, to diagnose them, we need lumbar puncture? Which one of these diseases, to diagnose them, we need lumbar puncture?
Meningitis.
Meningitis. Very good. Give me 2 signs positive in meningitis. 2 assessment signs positive in meningitis. What are the name of the 2 signs? We got this last time. We reviewed neuro. Huh? Brzezinski and yes, second one. Kearney's. Kearney's sign, Brzezinski sign. Yes, Kearney's sign and Brzezinski sign. This is positive in meningitis. Review last time notes. Okay. Then the airborne, guys, when you need your N95, this is your music, TVs, TVSS, M for measles, this is airborne, T for tuberculosis, this is airborne, V for varicella, which causes chickenpox and shingles, S for smallpox, S for SARS. This is your N95. Okay. Airborne patient, do we need to put them in positive pressure room or negative pressure room? Give me your voice. Positive or negative pressure room?
I want to say negative.
Negative pressure room, because we need to suck all the infection from the air in the room. Yes. Okay. Let's talk about TB, more about TB. TB, guys. What is the other name for the TB test? Sometimes the question doesn't say TB test. It gives you other name. They might say
Mantoux.
Mantoux. Yes?
Yes.
Yes, exactly. Very good job. Mantoux test, what I just did.
Interferon.
Yes, Mantoux test, very good.
Interferon.
Mantoux test, quantiferon.
Quantiferon. There it is.
Quantiferon, yes, very good. The Mantoux test, good job. Also, they call it PPD test or purified protein derivatives. And that test, they do what type of injection they do here in this forearm area? What type of injection? Intramuscular,
Intradermal.
intradermal. Good job.
Thermal.
Intradermal. So they do it intradermal. They put the very small amount of the TB test, and then they wait for how long? How long we wait and ask the patient to come back to read the TB test?
After 48 hours before 72.
48 to 72 before 72. Perfect. Okay. Positive TB test. If you see what? Redness, which we call it erythema, and it doesn't have to be only red. It has to be redness or erythema and induration. Induration means hardening. Yes?
Mhm.
How big is the erythema and the induration? It has to be bigger or equal to how many millimeter to consider it's a positive TB test?
It's 2 or 4.
5.
Yeah, I think it's 5.
5.
Okay.
Could be.
What about 10?
10 is definitely
More.
positive.
It is 10. It is 10 is positive. 10 is positive. 9 is negative.
Mm.
9 is negative. Yeah. So only we consider if it is more than 5 millimeter if the patient is immune compromised. Like if he's HIV patient or patient with low immunity and they got this erythema and the induration 5 millimeter or bigger, this is positive. But for everybody else, it has to be 10 millimeter or bigger.
Mm.
Yes?
Yes.
Okay. Does every TB test, positive TB test, means there is active TB?
No.
No, because TB test means there is antibodies in the patient body against TB. There is antibodies. Antibodies, it might be because of previous exposure, but the patient doesn't have any active TB, or maybe because of a vaccine. Vaccine, some countries, they give TB vaccine, and the people get positive TB test because of this vaccine. Okay, let me see your messages because there's people here. There is people cannot get in.
Mhm.
1 second, guys. Did everyone join the meeting easily, or you had to put the passcode?
Yeah, we had to put a passcode.
Okay.
The one that you sent worked.
Okay, good.
No, I don't know if you have a Teams account. It didn't ask me for a passcode.
I didn't need a passcode either. I just had to log in with my personal Teams.
Yeah, just
Oh
with
yeah, I
your
don't
personal.
have an account.
Yeah, just don't do the school one because the school one will not let you in. I believe you do the personal or use the passcode. Okay. Okay. So okay, guys. For TB test, if it is positive, the nurse anticipate what will be next step after positive TB test. What we do? I'm ready for the chat.
Mm.
What we do if there is a patient with positive TB test?
Isolate them.
Yeah.
Isolate them.
Negative pressure room?
Put a
Okay.
N95 on.
You need a
You
chest
confirm it with the
X-ray.
X-ray.
We
Chest
need,
X-
yes,
oh.
like Justine, Andrea. Confirm with a chest X-ray because he's not a TB patient. As I said, you don't diagnose or diagnosis will not be done with a TB test. TB test means there is TB antibodies in the blood, which could be from previous exposure, but it doesn't mean that this patient has active TB. So next step, the nurse expect the doctor will order chest x-ray and they give, even if there is no active TB, they put the patient on a medication for 3 months. What medication they give for the patient with positive TB test for 3 months? Huh? What
Rifampin?
medication?
Rifampin?
The other one. They give isoniazid. Good job, Gianni, on rifampin, but this is not the one. They give isoniazid or INH.
Don't they give like
INH.
5 of them or something like that?
Yes. Now, if the patient, guys, has active TB, if the patient diagnosed with active TB, what is the medication? They give 3 medications for 12 months. And the medication should be given all together. 1, 2, 3. Let's review the medications here. Number 1, Gianni said rifampin. Yes, rifampin is one of the medication. We call it rifampin or rifampicin. It is the same. So this is the rifampin medication. First line is INH or isoniazid. Third one, any help? Any help? Anybody started to recall the medications? TB meds?
It starts with a P.
Start with, yes, start with a
Mhm.
P.
It's Pyra, but I'm thinking about the
Pyrazinamide. Good
Okay.
job. Good job, Jose.
Mm.
Pyrazinamide. Good
Nice.
job. Pyrazinamide. And there is last one also they might give. There is pyrazinamide and ethambutol.
Mhm.
So we have these combination, isoniazid, rifampin, pyrazinamide, ethambutol, but these medication need to be given 3 of them same time for up to 12 months. After the 12 months, okay, guys, do we consider this TB patient is TB negative or free? How we conclude this patient is now TB negative?
With the chest x-ray or PPD?
PPD for how many times? Good job. PPD for how many times?
Is it 2?
3 times.
3
Just
times.
Oh,
3 times, yes. After 3 times of negative TB test, this is TB free. He is cured. Because sometimes they take the medication and they still have the positive test. It has to be 3 times of negative TB test. The thing of the TB medication, not anything other than the pain of the medications, not pain like pain. I mean the side effect. They have very serious side effects. Let's talk about the INH. What INH side effect, guys? What do you expect if the patient taking INH? And what side effect? Side effect means undesired effect. What the INH could cause? Yes. Huh? Any idea? Neurites. What is neurites? What neurites means? Neurites. It is inflammation in the what? Nerves. Neuritis, like inflammation. Come on, guys. Neuropathy. Good job, Destiny. Destiny put the word. Good job. This is neuropathy, which is, or neuritis. Neuropathy means nerve disease, or neuritis, inflammation in the nerves. So I have the subtitle on. Yes, so neuropathy or neuritis. Okay, what lab work the nurse expect to be ordered if the patient taking isoniazid for long time to monitor for side effect? What lab work the nurse expect to be ordered for a patient taking isoniazid for long time to monitor side
function?
effect? Liver function, you said? It is liver
Liver,
function.
kidney?
Liver function. Liver function test. Isoniazid, guys, hit the liver. So make sure that liver function test will be ordered, which is AST and ALT. Liver function test is AST and ALT. Okay? Second medication, which is rifampin, it causes a very common side effect. What side effect of rifampin, guys? It causes anybody? Rifampin cause yellow discoloration of all the body secretions. Their saliva. I know it comes. It comes. I see your head nodding. Yes, we know this, but we need to practice kind of more questions to get this back. Yes. So yellow discoloration of the all body secretion, like sweat, saliva. So you will tell the patient you will have some yellow discoloration of the body secretions. That will be normal, and that will stop after you stop the medication, which is rifampin. Then ethambutol could cause cataract. The pyrazinamide, it might cause ototoxicity. It is ototoxic. So you see every one of the TB medication could cause some of the side effect. That's why it is not the most pleasant thing to get the TB medication. Okay. So isolation precaution, guys. We said they might ask about PPE, or they might ask about, let's wrap up here. They might ask about also what patient could be cohorted with what patient. So this is a very quick practice to tell us what patient we can cohort with what patient. So I will ask one question here. This one. Can I cohort in the same room patient with positive PPD test and patient with positive acid-fast bacillus test? Again, can I cohort in the same room these two patients? First patient is positive PPD test. Second is positive AFB, is acid-fast bacillus. Can I do that in the same room? Yes? No? What does acid-fast bacillus means? It means they have what? Acid-fast bacillus. This is what? TB. TB. You know, when you do sputum test to check for acid-fast bacillus, this is for the TB. So patient has positive acid-fast bacillus test, means the sputum shows the bacillus, the bacteria. Can I cohort this patient with positive PPD test patient in the same room? Yes or no? Put me on the chat, either yes
no.
or no.
I would say no, just because one of them could be false positive.
Exactly, because TB positive, it doesn't mean they have TB. It means he might have exposed, or he might have the vaccine. It's not concluded yet. So I cannot just put, I have positive PPD test. I always have it positive because I got the vaccine in my country, guys. So I always have it positive. So I don't do the regular TB test. I do the quantiferon because quantiferon, this is the one which is more accurate.
Oh,
Okay? So patient with positive PPD test cannot be with acid-fast bacillus because PPD is not a TB patient yet. Okay, good. Second question I will take here. Patient with measles. Can I cohort him in the same room with patient with complex spots? Yes or no? Measles, complex spots. Yes or no? What is complex spots? What is a complex?
Meningitis.
Raiden? What did you say, my dear? Andrea, I see you saying something, but I can't hear you. Okay. Complex spots, guys. Look at this.
say yes.
Yes. Why yes? Good job. It is yes. Why yes? Because this is a complex spots. Complex spots, this is high yield, guys. Complex spots, these dots in the pharynx, in the throat, we call it complex spots. What are these? These are the spots which will show, it will show 2 days before the measles rash start. So this is the first sign of measles. Yes, so it will be measles later on. Yeah, Ranisha, Coral, yes, everyone.
Yeah.
Glad
Yes,
to
I
see you
listen
all.
here.
Glad to see you all. Eduardo, many people joined after, so welcome everyone. So yes, I can cohort a patient with measles with patient with complex because it is the same, right? Okay, very good. Can I cohort a patient with leukopenia with patient with neutropenia in the same room?
Yes.
Yeah.
Yes, because both of them are what?
Neutropenic.
Neutropenic, very good. And the cohorting or rooming in concept said we can cohort neutropenic to neutropenic. Very good, very good. Can I cohort patient with HIV with patient with AIDS?
The same thing. Yeah.
What is HIV? What is AIDS?
I want to say yeah.
I think no.
I was gonna
no.
say no.
Okay, look at the cohorting or rooming in concepts. Rooming in concepts say we can do standard to standard, we can do neutropenic to neutropenic, and we can do standard to neutropenic in the same room. Okay, so HIV is what isolation precaution? HIV is standard.
Neutropenic. Oh, no, standard.
And what about AIDS?
Neutropenic.
Neutropenic. So the cohorting saying we do standard to neutropenic, right? We can do that. HIV is a standard, AIDS is neutropenic. So we can have them together in the same room. Make sense? Can I have peptic ulcer with leukemia in the same room?
No.
No.
Why? Again, look at the cohorting.
Mhm.
Cohorting saying what? You can cohort.
Yeah, you can.
Neutropenic.
Yeah.
Standard to
Yes, you can.
neutropenic.
You can do standard to neutropenic, guys. I can do peptic ulcer with leukemia because I can do standard to neutropenic because there is no danger will happen to any of them. He's having just peptic ulcer. That will not hurt the leukemia patient. So I can have him in the same room. Leukemia doesn't have anything to infect the peptic ulcer, so they are safe to each other.
Mm.
Yeah? So remember, we can take any of the standard together in the same room. We can take any of the neutropenic together in the same room and we can mix standard and the neutropenic. Yes?
Yes.
Okay. Okay, now I will show you some. Oh, I hear myself.
Sorry.
No worries. So now I'll show you some pictures and you tell me, guys, what kind of infection this could be and what kind of isolation precaution. Is it a standard, the neutropenic, contact, or airborne? And you tell me what is a PPE. Cool? Okay. What is this? What do you see here? It looks like a strawberry tongue. Yes?
Mm-hmm.
Yes. So what could be this? What disease? What kind of infection giving strawberry tongue? Yeah. What infection gives a strawberry tongue?
Be like this one.
Anything on the chat here? Okay. Strawberry tongue. Scarlet fever. What do you think? Scarlet fever gives a strawberry tongue? Yeah?
Yes.
Kawasaki disease gives a strawberry tongue? Kawasaki? Let's put both. If it is a scarlet fever, let's go first with a scarlet fever. Scarlet fever, it gives a strawberry tongue. It gives low-grade fever, sore throat. Is it bacterial or viral?
Bacterial.
Bacterial. So we give antibiotic, right? Okay. Isolation precaution. Look at the table.
Droplet.
It is droplets. Good job. So what PPE?
Mask.
Surgical mask. Very good. Surgical mask. Wonderful. If it is Kawasaki, because Kawasaki also cause a strawberry tongue. Kawasaki cause a strawberry tongue, and it cause fever. It cause lymph nodes, right? Yeah, enlarged lymph nodes, abdominal pain. Yeah. So if it is Kawasaki, guys, what kind of isolation precautions? Huh.
Because it's the 2 days before measles, so airborne.
Wait, this is not complex.
Oh my gosh, okay, sorry.
Many names, right? Yes, it's okay. So Kawasaki disease.
Kawasaki. That's
Kawasaki.
the HIV. That's the AIDS. Those are the bumps, the skin.
Kawasaki, it's a child presented with fever, redness in the palms, in the feet, lymph nodes, strawberry tongue, abdominal pain. This is autoimmune, guys. Kawasaki is autoimmune. It is not contagious. Kawasaki is not contagious. It is autoimmune. So what kind of isolation precaution in Kawasaki?
Neutropenia.
What is the
Neutropenic. So what kind of PPE?
surgical mask?
Surgical mask. Good job. Yes. Okay. Then this is complex spots after 2 days, rash, papular rash, and fever. What is that?
Chickenpox.
Complex spots comes with measles. So this is measles. For measles, what isolation precautions, guys?
Airborne.
Airborne. Very good. What kind of PPE?
A negative
And
pressure
95.
room.
And
And
95 and negative pressure room. Very good. Okay. Then this one. They will describe it in the question as fluid-filled vesicles. Fluid-filled vesicles. And it is one line. In one line, it takes the distribution of the nerve. It takes
Shingles.
nerve. Yes, shingles.
Yeah.
Very good. Shingles. What is the other name of shingles? Herpes. Herpes zoster. Very good. What is the reason of herpes zoster? Is it viral, bacterial? Virus or bacteria?
Viral.
Viral. Very good. What kind of isolation precautions? Look at the table.
Airborne.
It is airborne. What kind of PPE?
N95.
N95. Very good. Very good. Okay. This guy with slapped cheek. Slapped cheek. This is one of the infection. We call it fifth disease or erythema infectiosum. This is one of the droplets, guys. Isolation precautions and needs surgical mask. Slapped cheek or fifth disease, one of the pediatrics infections. Okay. Ew, what is this?
Dandruff.
Pediculitis.
Pediculosis. Pediculosis. Very good. What kind of isolation precautions?
Don't go in the room.
Run. I will run with you. I will run with you.
It's
This
contact.
is contact. PPE.
Gowns and gloves.
Great. Okay. This one. This is a penis, guys, and this is chancre sore or canker sore. Chancre. Who remember this in what disease? In the genital area.
Is it syphilis?
Syphilis. Very good. Syphilis. Very good. What kind of PPE? STI. STI. It's a standard, but if there is active lesion, it will be
Contact.
contact. Very good, guys. Okay. This one. Silver scales. Itchiness. Silver scales in the elbow and the knee. What is this?
Psoriasis.
Psoriasis. Very good.
Mhm.
So proud of you here. Psoriasis. What kind of isolation precautions?
Standard.
Standard.
Yeah.
Standard. Standard. Okay, PPE is your gloves. Wonderful. This one. It is called bull's-eye or target shape.
Using
Would that be from Lyme
Lyme
disease?
Lyme
Mhm.
disease. Very good. Lyme disease. Isolation precaution. Does it go from person to person?
Mhm.
No.
No.
So contact? So, I'm sorry,
It-
standard?
Standard.
Mhm.
Yes.
And gloves. Mhm.
It is standard. Yes. And the gloves. Very good. And this is a tick bite which caused Lyme disease. It's caused by deer tick bite. Okay. This one. It is a childhood infectious disease. There is papules, there is pustules. So papule is a red elevation. We call it just papule, like pimples. There is pustule, which if it is filled with pustules. Some of them are crusting. So
That
crusting.
looks like chicken pox.
It is, Roxy. It is a chicken pox. Very good. What kind of isolation precautions?
Contact? Oh no, I'm sorry. Airborne.
Airborne, the varicella. Airborne. Very good. Very good. And this is a PPE for N95. Okay. This lady.
Butterfly rock.
Is that
Butterfly.
Lupus.
Lupus.
Yeah.
Awesome. Good job. Look at you. What isolation precautions?
Neutropenic.
Neutropenic,
Neutropenic. PPE?
surgical mask.
Surgical mask. Wonderful.
Mhm.
Okay, guys. Scabies. Oh, sorry. This is, guys, scabies. I said it. So this is scabies, and scabies is between the fingers, severe itching, and this is what kind of isolation precautions? Scabies,
Mm.
Contact.
contact, PPE.
Gown and gloves.
Yes, perfect. Very good. Okay. Now, what is this? Yes, say it. Good job.
Conjunctivitis.
Conjunctivitis. Conjunctivitis. Very good. The pink eye. Then isolation precautions. Contact. For how long? Because the mom is calling the nurse when my kid can come back to school.
Is it a
After being on
week?
antibiotics for 24 hours.
24 hours after antibiotic. Kai, very good. 24 hours after starting antibiotic. Hey, Kai, good to see you here. So 24 hours. What about the PPE for conjunctivitis? Since it is contact, the PPE is gloves and gown. Okay? Okay, guys. So this is isolation precautions. Make sure you study the table I give you. Make sure you know each disease and how to cohort patients together. There is a cohorting, a standard of cohorting. Read that and apply it to your questions. Okay? This is the first part. And let's take 10 minutes break and start on musculoskeletal and endocrine right after. Yes? 10 minutes. Let's come back 5:17. See you guys. Okay, guys, I believe the 10 minutes are over, and let's get back to our musculoskeletal. Musculoskeletal is one of the very short. Yes, are we ready? Are we back? It is very short
Mhm.
and kind of the diseases in musculoskeletal. I see you confused about the names of the diseases. Like, what is osteoarthritis versus gout versus osteoporosis? What each one exactly is. So let's start by this question. Okay, let's read the question together. The question says, what is the outcome criteria for a client with osteoarthritis? Or the outcome criteria for the client with osteoarthritis include. And the options are joint degeneration arrested, joint range of motion improved from 30 degree to minimum of 60 degree, 3, able to self-administer gold compound safely, 4, feels better than before admission to hospital. So what do you think? Outcome criteria for osteoarthritis. 1, 2, 3, 4. Don't answer, think about it. You guys use the rule out technique and send me the number 1, 2, 3, 4 on the chat. So everyone will have time to think about the answer and send me on the chat what do you think. More people. More people. Thank you, Jose. Thank you, Brittany. More people. What do you think? What's your input? What is your input? 2 or 3? Okay. Okay, Justine. Chanel. Raiden. You cannot say something without knowing why. Drea, you need to say why. Okay. Okay. So let's start. Okay, I got all the numbers. I got 1, I got 2, I got 3, I got 4. But before I reveal the right answer, it is improvement, yes. Number 4 is improvement, Drea, as you said. But what number 4 said? Number 4 say, feels better than before admission to the hospital. Feels better. What feels better means? Can you measure this? Can you measure this? Maybe my pain was 10 out of 10 and feels better like I'm 8 out of 10, right? So we never take subjective data. This is not objective. It is, remember guys, we said we do not use vague data. We do not use subjective data as something we rely on or as a criteria we expect as outcome for certain disease. So feel better. Who can measure feels better? Who can measure this? I can't measure feels better. So I will not take number 4. I will rule out number 4 because it is subjective. I better have something objective. So the answer, good job. I got Justine said 2, which is joint range motion improved from 30 degree to minimum of 60 degree. Because this is measurable, And this is good for osteoarthritis, right? I will take number 2. I will not take number 3 for people who chose number 3 because gold compound is not for osteoarthritis. This is for the rheumatoid arthritis. If this is a treatment for the rheumatoid arthritis, you give the sodium gold. So the gold is not for the osteoarthritis. Number 1, to who choose number 1? I will not take number 1 because osteoarthritis will not be arrested. Joint degeneration and osteoarthritis, guys, it doesn't stop. It's a progressive degenerative disorder. It's a progressive disorder. So I'm glad with number 2. Yes, Gianni, good job on number 2. Justine, good job on number 2. Roxy, it is 2. But the other ones, we rule them out. So I don't want you to choose something because you just want to choose it. I want to choose number 4. I don't know why. You cannot choose something without rationalize why this is my answer. And remember the strategies, guys. We said we will not use subjective data as our outcome. We always need something measured. Right? We can measure the range of movement. I will take this. Make sense? And osteoarthritis, it doesn't stop, guys. Osteoarthritis, it is degenerative disease and it's progressive. Okay? So let's talk about the diseases. What is osteoarthritis versus rheumatoid arthritis versus osteoporosis versus gout? Let's talk about it briefly. Number 1, osteoarthritis. Here you go. This is osteoarthritis. Look at the joint here. You see how each bone, it has, what is this blue color? What is this blue color at the end of the long bone? Do you see this blue color here?
Yeah.
Is that cartilage?
This is a cartilage.
Cartilage.
Yeah. So osteoarthritis, the cartilage will degenerate. It will go like degenerate until it is very like bone on bone. Later on, this is when they do knee replacement or hip replacement. So this is osteoarthritis. It's a degenerative and it is progressive disease. Mostly it affects the big joints. It could affect one side or two sides. Could be one knee or two knees. It doesn't matter. It doesn't have sex preference. It is male and female are equal. People with osteoarthritis, they get degeneration. What types of degeneration? Like sometimes they get enlargement in the proximal joints of the fingers. We call it butchered nodes. Butchered nodes. Sometimes they get degeneration in their knees, like the knees go far from each other or the knees go lock the knees. So we call it geno varus or geno valgus. These are the knee. Geno means knee. So geno varus, geno valgus, these are the deformity which happen with osteoarthritis. And we have butchered nodes here or Herbendian nodes. So this is the spelling, butchered Herbendian nodes. What is your intervention? What is the reason for this? What makes the joint degenerate? What makes the joint degenerate? For sure, number 1 is degeneration happen with what age?
Old age?
Old age, right? Can we stop aging?
No.
We cannot stop aging. There's another reason for osteoarthritis, which is weight, obesity or overweight, right? So one of the nursing intervention for patient with osteoarthritis will be weight management. Yes, advice about weight loss, right? When there is pain, what kind of compressions? Do we do hot compression or cold compression? Not hot, I will say warm compression or cold compression.
Warm compression.
The warm, because this is inflamed here, right? So remember, when there is inflammation, guys, we do warm compressions. Warm compressions, any compressions, it has to be 20 minutes and never right away on the skin. It has to be tissue to separate the compression cloth from the skin, so you avoid skin damage. NSAIDs, non-steroidal anti-inflammatory, is a treatment like ibuprofen, naproxen, all these medications. Okay, if patient with osteoarthritis and taking ibuprofen frequently, what the nurse need to monitor? They have osteoarthritis, they take ibuprofen frequently, maybe 3 times a day. What the nurse need to monitor?
Liver and kidneys.
Liver.
Which one, liver or
The liver.
kidney?
Liver.
The
Liver.
NSAIDs, they are bad for the
Kidneys?
kidney function. Yes, good job, Lori, good job, everyone. So what else you want to monitor for? What else? They are taking NSAIDs.
Ulcers, bleeding.
Good job. Yes, GI bleed, GI ulcers. Yes, because that could burn the stomach. So monitor for bleeding, GI bleed. Also, NSAID should be taken with full cup of water and never on empty stomach. Never on empty stomach. Okay. Then the rheumatoid arthritis, guys. So this is osteoarthritis, okay? Then what is rheumatoid arthritis? Rheumatoid arthritis is different. Rheumatoid, guys, this is autoimmune disease, common in females. So females are risk. Being a female put her at risk of rheumatoid. Rheumatoid is symmetrical. It comes in both sides. And it affects small joints, not like osteoarthritis. Osteoarthritis get the knee, get the big joints. The small joints, bilateral small joints in a female, this is rheumatoid arthritis. It is autoimmune. The immune system attack the small joints in the hands and the feet. Remember, it is symmetrical, presented with morning stiffness. She wakes up in the morning very stiff. And the deformity happens with rheumatoid arthritis. They look like a swan neck deformity. Look how it looks like a swan neck. Or the hand will be deviated toward the ulna. The ulna is a bone here, so there will be ulnar deviation. They will have deformity like this, like they have deviation in the hand. So ulnar deviation or swan neck deformity. You guys make sure you know the name of the deformity. Ulnar deviation, swan neck deformity happen with what disease? Rheumatoid arthritis, which is autoimmune. It destroys the small joints. It affects symmetrical side, both sides. It causes morning stiffness and common in females. Since it is autoimmune, we need to, number one, during the attack, when she has a pain, they give NSAIDs. And other autoimmune approach, like any autoimmune, they give methotrexate, they give the adalimumab, infliximab or Remicade, Humira, all these, and sodium gold, here the gold. The gold is in the rheumatoid arthritis. So the approach for rheumatoid is different because it is autoimmune disease. Cool? Yeah? Then, what is next? Osteoporosis. From the name, osteo is bone, oste is bone, pore is pores. So osteoporosis, there are pores in the bone that decrease in the bone density. Who is at risk of decrease in bone density? Huh? Who is at risk? Elderly? Yes.
Women.
Elderly and?
Women.
Women. Good job. Why women?
Because we don't take enough calcium and vitamin D.
Okay, oh, we should take them, right? What they lack, women after certain age. What they lack after menopause that will cause decreased bone density. What hormone?
Is it estrogen?
Estrogen.
Mm.
Yeah, estrogen. So lacking the estrogen after menopause, that will cause osteoporosis. So osteoporosis, it is common in women after menopause because lack of estrogen. Estrogen is important for bone density. So I put like the bone will be like Swiss cheese. Like bone, it has pores like the Swiss cheese. Okay. What kind of, is there any ethnic group, like certain ethnic group common to get osteoporosis? Like, can I say like African American more or Asian more? What do you think? What ethnic group common to get the osteoporosis, the low bone density, the
Is it Asian?
Asian and good job, Jack. Yes, good job, Roxy. Asian and white. Very good. What kind of body type? Is it common in obese or small body?
Small.
A small body.
Small. Very good. So you look at this. Common in small body. Yes. You guys, you see her, she's not happy, but you're good. You will not get the osteoporosis like her, but you might get what disease if she's obese? What musculoskeletal disorder?
Osteoarthritis.
Osteoarthritis. Yes, very good. But osteoporosis common with females, gender, females, postmenopause, Caucasian, like white, and Asian. Very good. And the bad habits also like smoking, alcohol, all these might cause osteoarthritis, plus excess caffeine also might cause osteoarthritis, excess caffeine. Okay, so this is osteoarthritis. So sorry, osteoporosis. Then gout. The last disease here is gout. Gout is problem in metabolism of uric acid. The uric acid is not metabolized well, so the uric acid and purine products accumulate in the small joints like the big toe or any joint. Yeah? So the uric acid accumulate, it gives severe pain and swelling. So we need to put this patient on certain diet. We need to put them on diet,
Low purine.
low purine diet. What they should not consume. What kind of diet is high in purine? So they shouldn't take. They should
Red meats?
avoid what? Yes, red meat. They should avoid red meat because it is high in protein. What else?
Organ
Uric
meat.
acid.
Something
meat?
rich in uric alcohol. Yes, no alcohol, rich in purine also. Shellfish, right? Yes, so red meat, alcohol, shellfish, all these are rich in purine, so they need to avoid food rich in purines. Plus, you give medications like NSAIDs for the pain, for the inflammation, anti-inflammatory, colchicine, which is a gout medication. Probenecid also is a gout medication. Allopurinol is a gout medication. Yes? What the nurse need to monitor if the patient taking colchicine? When I say need to monitor, it means what? Need to monitor, it means it is
It's an adverse
something
effect.
undesired. Yes,
Undesired.
something undesired. Like could be side effect. Like what is a side effect of colchicine?
Mm,
Huh. It causes severe GI symptoms. GI, like it
nausea and
causes
vomiting.
nausea, vomiting, and bloody diarrhea sometimes. If it causes bloody diarrhea, this is an adverse reaction. They need to stop the medication. Yes, it causes severe nausea, vomiting, but if it causes the adverse reaction, which is bloody diarrhea, they will stop the medication. Yeah, so these are the musculoskeletal ones. Okay. So now we know the difference between the big ones because I saw some exams. I saw you guys confused between which one is osteoarthritis, which one is gout, which one is rheumatoid, which one is osteoporosis. Hope that made it clear. Yeah. What else in musculoskeletal important for our NCLEX? Please review the gaits. We went over that before. Types of gaits is high yield, how to use cane, how to educate your patient to use walker, or how to transfer your patient from the bed to the wheelchair or from wheelchair to the bed. Yes? Let me ask you a question. Cane, how to use the cane going upstairs. Cane going upstairs.
Is it on the unaffected leg?
Cane on unaffected leg.
Oh, on the affected leg.
Okay. Have I mentioned this mnemonic before for the cane?
No,
C-
but I did get something wrong about a cane.
Coal. Coal, C-O-A-L. Okay. Cane, opposite, affected leg. Cane opposite to the affected leg. So you have the cane on the good one. Okay? Cane opposite to the affected leg. Cold. So going upstairs, have your cane opposite to the affected leg. And when you go upstairs, you go upstairs with the good leg first. Have the good leg upstairs first. Take it up first. So start with the good leg when you're going up. Imagine you're going up, you're going to the heaven, you're going to a good place. So take the good leg with you. So good leg start going up as you're going upstairs first. But when you're going downstairs with using the cane, going downstairs you're going to hell, So the bad leg, let's take it to the hell. So go with the bad leg first as you go downstairs. Make sense?
Mhm.
Yes. Okay. So this is all about musculoskeletal. And now let's do endocrine. Ready for endocrine? I cannot, guys, tell you enough how important is endocrine. Endocrine is huge, huge, and nobody go with low performance in endocrine and they will not catch it because there are many variety of endocrine questions. They might ask about diabetes, they might ask about insulin, they might ask about thyroid, they might ask about Cushing, they might ask about Addison disease, many endocrine disorders we need to be aware of. So let's make endocrine today different. I know endocrine is kind of challenging. Yes, who feel endocrine is a challenging topic for you? Who feels endocrine could be one of the challenging topics?
Me.
It's challenging for me.
It is, yes or no?
It is.
It is. Anybody else?
Yes.
You feel it is
Yes.
kind of...
Yeah.
Okay. So what about we will study endocrine? Yes, Treya put good goes to heaven up, bad goes to hell down. Yes, very good. So let's make endocrine today's study is different. Let's make the endocrine, we will not study like, oh, this will happen with thyroid, hyperthyroid, so it will be this and this and this. Hypothyroid will be this and this and this. We will understand endocrine because if we don't understand endocrine, it is kind of challenging to answer endocrine questions. So let's understand it. And how you understand the endocrine. Let's start by the first gland here. We will talk about endocrine based on glands. We have glands, endocrine glands in our body. Each gland produces certain hormones, guys. We know that, right? Each gland produces certain hormone. Yeah? These hormones, it has to be in certain level, like certain level in the blood. The amount of the hormone in the blood, it has to be in certain level. If the hormone level go high, or if the hormone level, it goes low, that is endocrine disease. Okay? So, endocrine is all about the hormone level. Sometimes it is high, sometimes it is low. If it is high, it's a disease. If it is low, it's another disease. But the good thing is the two diseases, if the hormone is high and the hormone is low, the two diseases are opposite to each other. So you just know one of the diseases, the other one will be opposite right away. Yes, let me explain this. If we start by the thyroid gland. So first, these are the diseases of endocrine we want to study. We will study thyroid, parathyroid disorder. We will study diabetes insipidus and SIADH. We will study pheochromocytoma. We will study Cushing versus Addison, and then diabetes. Let's start by the thyroid. As I said, we will go by gland. Yes, we will make endocrine make sense today. We will talk about the gland, and we will talk about the hormone produced by the gland. And we will talk about what will happen if the hormone is high and what disease will happen if the hormone is low. This is all about this, all about the hormone level. If it is high, there will be certain disease. If it is low, there will be certain disease. To know the disease, we need to know the function of the hormone. You want to know how the hormone affects the body. So what is the function of the hormone produced by certain gland? If you know the function of the hormone, you will know what will happen if there is high amount of this hormone or low amount of this hormone, right? Yeah, so if you know what the hormone does, you will know what will happen to the body if this hormone is high in the body, or what will happen if this hormone is low in the body. Yes? Makes sense? Yes, no?
Yeah.
Okay, so thyroid gland. Let's start by the thyroid. It produces 3 hormones. Hormones are T3, T4, and calcitonin. Okay? T3 and the T4, both of them, what is a function of T3 and T4? They help with metabolism. What metabolism means? Make you burn your diet, burn your food to get the energy. Yes, this is the function of T3 and the T4. Yeah?
Yeah.
So let's imagine if the hormone is high, the disease will be hyperthyroidism. If the hormone is low, what will be the disease? If the hormone is low, it will be hypothyroidism, right? So we have 2 diseases opposite to each other. One is hyperthyroid, one is hypothyroid. One, there is increase in the hormone T3, T4. One, there is decrease in the T3, T4. One, the hormone is high in the hyperthyroid, so there is high metabolic rate. They burn fast. They have a lot of heat and energy in their body. And they burn fast, so they lose weight. So one of the diseases like this. The other disease, when they have low thyroid hormone, their metabolic rate will be high or low. If there is hypothyroid, the metabolic rate will be
Big.
Low.
Low.
low. So they will not burn their food. They will not get the energy, right? So let's talk about this. You have two diseases opposite to each other. One of them is hyperthyroid, which is increase in the T3, increase in the T4. So that will be increase in the metabolic rate, right? Increase in the metabolic rate. They burn fast. They burn very fast. So everything is hyper in their body. Yes? And on the other hand, the hypothyroid, they have low T3, low T4, and they burn very slow. Everything in the body is very slow. Make sense? So knowing the function will tell us what you expect as assessment. Because how questions come? Questions come as assessment. When you assess your patient, what will be the finding? Or they ask about lab work, like what plan, what lab you expect. You expect either high or low T3 and the T4, right? Then what is your plan? Like how to intervene, right? You ask about your intervention in this patient, right? So let's answer these questions. Let's answer what I want to assess, what lab work we want to check, what is the plan or what intervention, because what they will ask more than that. These are the questions they ask in any concept, right? So let's talk together. What finding you expect in each patient? Number one, let's talk about body weight. Number two, let's talk about heat and the cold, intolerance. Number three, let's talk about bowel movement. 4, heart rate. 5, blood pressure. 6, level of energy. Yeah, let's talk about this. So what about body weight? What do you think? There will be any changes in the body weight? If somebody burn very fast, what will happen to their body weight?
Hyper is
Hard
weight
to-
loss and hypo is weight gain.
Yes, exactly. Hyper weight loss. Look at the pants here. Look at the pin. They hold the pants with the bobby pin or what safety pin. Yes. So this is weight loss because she burns that high. But the weight gain in the hypo, they will have weight gain. So weight loss in here, weight gain in here. So assessment finding will be weight loss in the hyper, weight gain in the hypo. If they ask about nursing intervention, what kind of diet you will give to the hypo? You will give the hypothyroid low calorie or high calorie diet for the hypo?
Low.
Low, because she's gaining weight. But for the hyper, you will give what kind of diet?
High calorie.
High calorie diet. Yes? Okay. Then heat and the cold intolerance. Who will have heat intolerance? Like, I cannot stand the heat. It is so hot. I'm so hot already. I have that much energy. I have been burning. I have that much energy. Who will have heat intolerance? Hyper?
Hyper.
Hyper. Yes. So how you intervene with hyper? She has heat intolerance. I'm going to turn on the AC. Right? But for hypo, we'll have cold intolerance because she's not burning. Her body is always cold. I'm going to give extra blanket. Right? See how they ask. They ask about assessment finding or intervention. Yes? So you intervene according to your finding, right? What about bowel movement? Who will have diarrhea? Who will have constipation? Let's say number 1, this is number 2. Hyper is number 1. Hypo is number 2. Who will have diarrhea?
Hyper.
Number 1.
Number 1. Yes, because burn, waste, everything is fast, so diarrhea. What about the poor one? She's not burning, everything is slow, even bowel movement is slow. So this is a constipation. So which one the nurse intervened by giving laxatives?
2.
Number 2.
Number 2.
Yeah, number 2. Exactly. Then heart rate. Who will have tachycardia?
1.
1. Who will have bradycardia? 2.
2.
Right?
Two.
So which one I'm gonna give beta blocker? 1 or 2?
1.
1, because it has tachycardia, so I need to slow the heart rate with a beta blocker. See, this is how sometimes there is select all that apply questions, right? You
Mhm.
always see why I give beta blocker. Should I choose beta blocker as an intervention for hyper? Yeah, I will take it because she has tachycardia or my patient has tachycardia. I'm going to give beta blocker to slow down the heart. Yeah. Okay. If there is laxative, should I give hyperthyroid laxative as one of my select all that apply? Or the hyper, can I give laxative?
No.
No, because she's already having diarrhea or my patient is already having diarrhea, right? Okay. Who will be fatigued, sleepy, tired all the time? 1 or 2?
Two.
1. No, I'm sorry.
2.
2.
2.
Yeah, 2.
Because there's no energy, right? So fatigue, sleepy, tired. Who will be anxious, nervous, irritable?
1.
1. Yes. Yeah. So this is the hyper, this is the hypo. How we made it this way, I didn't say anything. You guys just told me the assessment finding. You guys just told me nursing intervention. Based on what? We understood the function of the hormone. How the hormone work? If it is high, what will happen? If it is low, what will happen? Yes?
Mhm.
Okay. Then sometimes they don't say hyper or hypo. They give you names, different names. Because sometimes they say Hashimoto's. You need to know Hashimoto's is hypo. So Hashimoto's is hypo. Sometimes they say mixed edema. It is also hypo, but it's an emergency of hypo. If it is very low, it's emergency, the mixed edema. For the hyperthyroid, sometimes they don't say hyperthyroid. They tell you goiter, Graves' disease, cyrotoxicosis. Yes? So be like aware of the other names and know, is it hyper or hypo? Makes sense? Now let's get to the treatment. How we treat hyper, how we treat hypo. Hypo, low thyroid hormone, is easy to be treated because you just give thyroid hormone. It is hypo, low thyroid hormone. I'm just going to give thyroid hormone. What is the name of that medication for hypo?
Synthroid?
Synthroid. Very good. Good job, Roxy. Synthroid. Or also they call it levo.
Lavoxerin or something?
Thyroxine.
Yeah, levothyroxine. The same. Levothyroxine. The thing is, it has to be early morning on empty stomach. On empty stomach. Early in the morning. Okay. Hyper. How we treat hyper? Hyper means thyroid is active, producing T3, T4, right? So we need to give medication to suppress the thyroid. What are the medication we give to suppress the thyroid? Number 1, we have this medication, which is PTU, propylthiouracil. Second medication is methimazole. These two meds. But these two meds are very high in their side effect. So they shouldn't be given for a long time. Also for hyper, they give beta blocker to treat the tachycardia. Beta blocker not to treat the thyroid, is to treat the tachycardia only, which is a sign in the hyperthyroid. Because these two medication we cannot give them for a long time, so if the condition not treated, they do thyroidectomy. They remove the thyroid gland. Sometimes they do radioactive iodine to ablate. You do ablation of the thyroid gland. Okay, so the thing is thyroidectomy, they open here in the neck, right? Is it safe area to have a surgery in the neck?
No.
Your airway, right? So after thyroidectomy, nursing intervention is very important because you need to know how to position your patient, what to monitor, because there is complication could happen after thyroidectomy. A complication after thyroidectomy is hypocalcemia. Hypocalcemia, low calcium level. The calcium level will go down. Yes, and these are the two signs. This sign, we call it Chvostek sign, and this is called trousseau. Chvostek and trousseau, guys. Don't forget these signs. Chvostek sign, which is when you tap with your finger on the patient cheek, the patient will wince, or there will be like a switch, like there will be switching in their cheek. And the trousseau sign, when you put the blood pressure cuff inflated, the patient wrist and the fingers, look what happened to the wrist and the fingers, constricted like this, or spasm, painful spasm in the patient wrist and fingers. This is called trousseau, this is called Chvostek, both of them hypocalcemia, low calcium level after thyroidectomy. Yes? Why low calcium happened after thyroidectomy? Because what gland behind the thyroid?
The parathyroid.
Parathyroid, Ranisha, very good. And the parathyroid is a gland which help with the blood calcium level. So if they remove the parathyroid, that will cause decrease in the calcium level. Very good. Yes? One more complication. Good job, guys. You did great job. You said bleeding, yes. You said airway obstruction, yes. Hypocalcemia, kudos to you, Ranisha. Good job, everyone, on that. And there's one more. It's kind of huge complication. Hey, Elizabeth. So what?
Is it the thyroid storm?
Yes, very good. So proud of you. Thyroid storm. What is thyroid storm, guys? When they remove the thyroid, some of the thyroid hormone escape to the blood. So there will be gush of T3, T4 to the blood. So that gush, it will cause super increase in the thyroid hormone. That will put the patient, after they remove the thyroid, they will put all the symptoms of hyperthyroidism. There will be tachycardia, high blood pressure, but this is emergency. You need your emergency team. Thyroid storm, this is emergency. Very good job. So complication after thyroidectomy, guys, remember one of them is the thyroid storm, which could happen because of the release of the thyroid hormone. Thyroid storm here, I have it here, occur when there is increase in the thyroid hormone in the blood after surgery. It causes hypertensive crisis. It is emergency. Very high blood pressure, hyperthermia, very high fever, increase the heart rate. Your goal is to make your patient stable. Make sure the vital signs go back to normal. Sometimes it is hyperthermia, very high fever. They do cooling blankets. They give beta blocker to lower the heart rate. So watch for the thyroid storm. Yeah? Okay, this is a thyroidectomy. And we talked about hyper and hypothyroid. Let's get this question, guys. Who helped me reading? Who want to help me reading this question? Until I get a sip of water. Go ahead, anybody.
A nurse is caring. A nurse is caring for a postoperative thyroidectomy client at risk for hypokalemia. What intervention should the nurse implement in this client care? 1. Monitor laboratory values daily for an elevated thyroid stimulating hormone. 2. Observe for muscle twitching and numbness or tingling of the lips, fingers, and toes. 3. Observe for swelling of the neck, tracheal deviation, and severe pain. 4. Evaluate the client's voice post-operatively and noting any drastic changes.
Thank you, Roxy. I'm not expecting anybody to tell me the answer. I will expect your chat, your lovely chat, guys. What do you think? The only thing here, Roxy, you read hypokalemia. It is hypocalcemia.
Hypocalcemia, sorry.
Yes, yes. So, yes, send me your answers before I reveal it. What do you think? Whoa, very good job, guys. All of you got number 2. Very good. Answer is number 2. Very good. Let's break down the question. Let's review how we read and break down our questions. Number 1, you need to read your question carefully. Let's review what we learned in term 1. Read your question carefully. Then confirm what is the question is asking. Question is asking, what intervention should the nurse implement in this client care? And the client had risk of hypocalcemia. So we're talking about low calcium level. So for low calcium level, monitor lab value daily for elevated TSH, thyroid stimulating hormone. Is that true statement or false statement? How monitor TSH help with calcium level? Does it help?
No.
No, so I will rule this out. Then, evaluate the client voice post-operative and note drastic change. I will take this if they don't specify hypocalcemia, because after thyroidectomy, they might have voice changes. So that could be a right answer if they just ask what you want to monitor after thyroidectomy in general. Because after thyroidectomy, you want to monitor for voice changes because hoarseness could be a problem. but they specify you want to have a client monitor for risk of hypocalcemia. So this not related to hypocalcemia. Then observe for swelling in the neck, tracheal deviation, and severe pain. That could be a post-op complication after thyroidectomy. But what kind of complication causes swelling in the neck, tracheal deviation after thyroidectomy? If there is what complication after thyroidectomy cause swelling and deviation in the trachea? If there is what? What do you think?
Swelling.
If there is a swelling or if there is bleeding, right? Yeah. So this is also could be monitored, but not for the hypocalcemia. Good job, guys. Hypocalcemia, it causes tingling and numbness. So because low calcium affects the muscle, calcium important for your muscle, calcium important for your nerves. So if there is low calcium, that will cause muscle twitch and tingling in the fingers. And this will be a good chance to remind you with hypocalcemia in general. Low calcium, hypocalcemia cause what? Remember this mnemonic. Cats go numb. Cats, no, you know how sometimes you hold your cat from their neck and they just go like this? Numb, they cannot move, right? You hold the cat from here and they do numb like this. So remember, hypocalcemia, remember cats go numb. This is a mnemonic. So hypocalcemia cause C, convulsions, A for arrhythmias, T for tetany. Tetany is severe hypocalcemia, guys. And tetany is this. Tetany is this. Wait. Tetany is this. This is when there is Chvostek sign, when there is Trousseau sign. This is very low calcium. This is called tetany. Yeah? So what is tetany? When there are these two signs showing very low calcium level. Yeah? So cats go numb. This is hypocalcemia. Convulsions, arrhythmias, tetany. Remember the Trousseau, Chvostek. Then go numb, numbness. Hypocalcemia cause numbness. Yeah, so this is hypocalcemia. Yep. So this is the thyroid gland and the diseases related to the thyroid gland. How do you feel about the thyroid disorders now?
Better.
Better or worse or the same? Thank you, Jose. Better. What about the rest of you guys?
No, better.
Better.
Yeah. Okay, good. Let's look at another gland. Yes? Let's look at the parathyroid. The parathyroid, guys, is at the back of the thyroid. So if this is the thyroid, look at the back. These four tiny beads, they are the parathyroid glands. The parathyroid gland, guys, function. Again, we said we need to know the function of the hormones. So if there is increase in the hormone, how will be the effect on the body? If there is decrease in the hormone, how the effect will be on the body. So for the parathyroid, the hormone produced called parathormone. And this hormone cause or adjust the calcium level in blood. Calcium level in the blood. Okay? So if there is decrease in the parathyroid hormone, what will happen to the calcium level?
Drop down.
Drop down. So it will be hypocalcemia. So we will go to the same story of cats go numb, right? So for hypothyroid, it will cause convulsions, arrhythmia, tetany, numbness, muscle cramp. So how we treat it? Just to give calcium, but calcium to be absorbed, you need to give with calcium, you need to give vitamin D. Right? On the other side, if there is hyperparathyroid, if there is hyperparathyroid, what will happen to the calcium level? Increase, right? So let's get what will happen to the body if there is hypercalcemia. There is another mnemonic here. I have it on the side for hypercalcemia. It is back me. Back me. B for bone pain. If the calcium is high, that will cause bone pain. Imagine your bone is full of calcium, that will be groaning pain. Then arrhythmias also. So calcium cause cardiac problem, either if high calcium or low calcium. C, constipation. High calcium, that will cause hard stool. K for kidney stones. Yes, calcium stones. Muscle will be also affected. How the muscle will be affected? It will be muscle weakness. And then hypercalcemia, it will cause excessive urination. Patient will have polyuria. So remember, please, these two mnemonics for hypo and the hypercalcemia. So this is hyperparathyroidism. Okay, guys, these are the two glands, thyroid and parathyroids. Okay, are you still breathing? Yeah?
Yes.
Let's keep going. Continue. Let's take another gland. Let's see what is the other gland. Okay, thank you for confirming. What is the other gland we will talk about after the thyroid gland? Let's talk about the adrenal gland. Sorry, guys. Let's talk about the ADH. Here, let me share the screen. Let's talk about diabetes insipidus. Diabetes insipidus. This disease. So, let's talk about hormone called antidiuretic hormone. Antidiuretic hormone. Do you see my screen? Yeah?
No.
I
No.
don't see anything.
Okay. I'm glad I asked. Okay. Second gland we will talk about. It is pituitary gland. It is in the brain and it produces hormone called antidiuretic hormone or ADH. So, second gland is pituitary. This is in the brain. Produce ADH or vasopressin. Know the name of this antidiuretic hormone, also called the vasopressin. It is important to know the other name. I will tell you why very soon. So we have antidiuretic hormone produced from pituitary gland. It affects the kidney. What is the function of this hormone? We agreed we need to know the function of the hormone, so we will be able to know what will be the effect on the body if there is increase of this hormone or decrease. Cool? Okay. So from the name antidiuretic hormone, antidiuresis, it causes what? Antidiuresis. Diuresis means what?
This one is
Uh,
causing edema and
Urination.
Urine.
Urination, right? So if I say antidiuretic hormone, it is antidiuresis, means anti-urination, so that will cause water retention. If this hormone is high, it will cause water retention, right? Yes? It decreases urination. Antidiuretic hormone, it is against urination, decrease urination. So it causes water retention. If the water retention is high, how that will affect the blood pressure?
Increase it.
Increase the blood pressure because more blood volume, more water in the body, more blood volume, more blood pressure, right? So the ADH increase the blood pressure, right? Also, this ADH or vasopressin, we said it is the same one. We call it ADH or vasopressin. Vasopressin means what? Vaso is what? Blood vessel, right? Pressin means what? Press, constrict, vasoconstrict. So also the ADH, it constricts the blood vessel. If there is constriction on the blood vessel, how that will affect the blood pressure? Huh? If the blood vessel is constricted, that will increase or decrease blood pressure?
Increase.
Increase the blood pressure. So from this slide, we learned antidiuretic hormone cause water retention, cause constriction of the blood vessel. Both effect will increase the blood pressure, right? Now the disease. If there is increase in the ADH, increase than normal, what will happen? What will be the disease? And if there is decrease in the ADH, what will be the disease? Okay, let's see. This is decrease in the ADH. The antidiuretic hormone is decreased. ADH is decreased. Antidiuresis is decreased. This is another disease, ADH increase. We call it SIADH or syndrome of inappropriate ADH. ADH is very high in the body. Okay, let's talk. If the ADH is low, let's think. Think with me, guys. Antidiuresis, antidiuretics, anti-urination is low. Will the patient urinate more or less? Anti-urination hormone, antidiuretic hormone, decrease. Will the patient urinate more or less?
More.
More. Good job. Because there is nothing to prevent the patient from urination. Right? ADH decrease, there is no antidiuresis, the patient will have polyuria or oliguria. Poly or oligo? Poly. Good job. Polyuria. It is increased urination. Polyuria. So patient with diabetes insipidus, they will have polyuria. Look at the patient. Look at this guy. You see what he's doing here? He's standing on the pond of the pee. He has pee. He's urinating all the time because there is nothing to prevent him from urination. Decrease in the antidiuretic hormone. So there is polyuria. Okay. So polyuria, what about thirst level? If he has polyuria, he will have polydipsia. What polydipsia means? Frequent. Do you see the picture? What is he holding in his hand?
Thirst.
Thirst. He's thirst because he's peeing that much, so he's thirsty. So polyuria, polydipsia will happen in diabetes insipidus. You guys, I don't want any of you at this point think diabetes insipidus is related to the diabetes mellitus. Diabetes mellitus is problem with the blood sugar. Diabetes insipidus not related to blood sugar at all. It is all about decreasing the antidiuretic hormone. Do you agree?
Yes.
I need thumbs up. You are behind the screen, guys. I leave you behind the screen. The ones behind the thing is the ones giving me their face and their thumbs in the screen. They confirm. Thank you for confirming. Yes, Chanel, Zach, everyone. Yes. So
Mhm.
there is polyuria, there is polydipsia, because there is no antidiuretic hormone to prevent them from pee. Okay. What will happen to the blood volume in patient with diabetes insipidus? Increase or decrease? Good job,
Decrease.
Elizabeth. Decrease. Very good, because they are losing blood volume. What will happen to the blood pressure?
Decrease. Hypotension.
Decrease. Very good. Hypotension. So when you get select all that apply in diabetes insipidus, you choose polyuria, choose polydipsia, choose low blood pressure. Yes?
Yes.
What will happen to the urine specific gravity? Are you going to choose low specific gravity or high? What will happen to the specific gravity if there is a lot of urine? It will be diluted urine, so they will have low specific gravity. If the urine is diluted, they will have low urine specific gravity, right? If they give you hypernatremia or hyponatremia of the choices, which one you will choose, hyper or hyponatremia?
Hypo.
Hypo. If they, okay, look at the picture. Let's understand here. The picture show they lose the fluid. They leave the sodium in the body. They lose the water. Sodium will stay in the body. Look at the body here, how it looks like. How it looks like here, there is a salt shaker and the water coming out and the salt staying. Look at this, the salt shaker. Do you see it? Yeah? Do you see this?
Yeah.
So if they lose the water, the sodium will stay. So this patient will have hypernatremia. Yes?
Yes.
So, yes. So now I understand. Now I understand why I choose these options when I get question on diabetes insipidus, why I choose polyuria, because he doesn't have enough antidiuretic hormone, so he's losing the urine. If he's losing urine, he will be cirrhosis, so polyuria, polydipsia. When he lose water, sodium will stay in the body, will increase. When he lose water, the blood volume will decrease, so there is low blood pressure. So I will choose polyuria, polydipsia, hypernatremia, hypotension. Yeah, high urine specific gravity. He has low ADH. So how I treat patient, what you expect, nurse? What you expect will be prescribed to patient with diabetes insipidus? You want to give him ADH?
Desmopressin.
Good job. We will give the desmopressin or the vasopressin, which he's lagging. He's lacking this medication. He doesn't have this hormone. He doesn't have enough vasopressin in his body. So we will give him vasopressin or desmopressin. And the very unique medication, this medication, the medication administration is different. How the nurse will administer desmopressin or vasopressin to the patient. How you will administer this medication? It is one of the very unique medication. It is administered intranasal. Whoa, intranasal. Intranasal, not, yeah? So it is intranasal medication, desmopressin or vasopressin. Yep. Yeah. Okay. And one of the memory joggers, you will remember, diabetes insipidus is DI, right? DI stands for dry inside. Whoa. So once you see the word diabetes insipidus, I want everyone here remember the DI, the dry inside. I want everyone to remember this guy, this sticky guy who is dry inside, who's losing the urine. Can we do that?
Yes.
Yeah? Can we use this picture to remember? Once now diabetes insipidus will not be a problem for us. I will remember the DI, dry inside. I will remember all these findings because I understood why this happens. Everyone is, are you breathing? Eduardo, I haven't heard you today. Carolina, Justine, the kids are taking you here. Knock, Sin, Mojabeng, Destiny, Zach, Chanel, all of you guys. How is it going? Gianni, Lori, Caslin, Melissa, Dria. How is it going here?
It's going
Focused?
good.
Are you focused? Just
Yeah.
quiet because you're focused.
I'm trying, but my kids are being crazy, so I just have it muted.
Justine?
Wow.
Okay.
Yeah.
Okay. Okay.
Thank
So,
you.
you're welcome. Then, guys, the other one will be the opposite. The opposite of diabetes insipidus is what? SIADH. SIADH is syndrome of increase in the ADH. So you tell me now. I will not say anything. It is exactly the opposite. Opposite of polyuria. What is the opposite? He will have what? Look at this. There is a stop sign. So what will happen to the urine? Polyuria.
Retention.
Oh, it could be first
Oliguria.
oliguria, and then they might have retention later, but oliguria at least, right? What will happen? There is fluid retention, yes or no? What will happen to the blood volume? Increase or increase? What will happen to the blood pressure?
Hyper.
Increase. What will
Increase.
happen to the urine specific gravity?
High.
High, because the urine is concentrated. Also edema, brain edema. They might get seizures because there is brain edema here. Cerebral edema. What will happen to the sodium? Increase or decrease?
Increase.
They don't lose fluid, so the sodium will be diluted. They don't lose the fluid, so the sodium will be diluted. See these white circles? This is the sodium. It is diluted here. So the sodium will decrease because it is diluted. Yeah? Makes sense? The
Yes.
most common reason, guys, and remember here, this is SIADH. Remember, SI means soaked inside. Soaked inside, though. This guy is soaked inside with the swelling. The other one is dry inside. And this is problem with what hormone? The ADH, the anti-diuretic hormone.
Mhm.
Hey, Maria.
Hi, Dr. Manal.
Hi. You just joined?
I did just joined. I forgot my son had a soccer game, so we just got back. I couldn't open this over there.
It's okay. Welcome. Okay, guys. So this is the second endocrine problem. I cannot like stress enough how important is endocrine, right?
Mhm.
What else is in endocrine? Cushing disease, and what is the opposite?
Addison.
Addison. Okay, I'll give you a break after this, okay? Promise. So let's talk about Cushing and Addison. We talked about thyroid, hyper versus hypo. We talked about diabetes insipidus versus SIADH. Now let's talk about Cushing versus Addison disease. And again, they are in your final lab packet. They are in tables. Like I am comparing between both diseases in the table in your final lab packet. There is a comparison. Do you see it, guys? Do you see how there is a comparison in your final lab packet? I just presented the same way in your packet. I presented in a way like table of comparison, hyper versus hypo. So diabetes insipidus versus SIADH, and Cushing versus Addison, because they are opposite to each other. So when you review them, your final review, you will have the same like way we learned them together today. Okay, so let's talk about Cushing versus Addison. What hormone? The hormonal problem in these two is the steroids, steroid hormone, or glucocorticoids. It might be cortisol. They are all the same. Steroid, glucocorticoid, cortisol. So the problem is in this hormone. There is increase in the cortisol level in Cushing, and this, what gland produce cortisol, guys? What gland produce the cortisol? It's a problem in what gland?
Adrenal.
Adrenal gland. Very good. Then the addison is decrease in the cortisol level. Okay. So, like every gland problem, we need to know the function of the hormone so we can expect what will be this assessment finding, right? So what is the function of the cortisol, guys? Cortisol, it has many functions in our body. Many functions. Number one function in our body, cortisol help to regulate blood glucose level. Yeah?
Yeah.
It increase the blood glucose level, increase the blood pressure, but increase them to normal level, like keep them high. So glucose, work on the glucose level, work on the blood pressure. Glucose also, cortisol, increase the glucose, increase the blood pressure. Cortisol also good for
Metabolism.
fat. It increases the fat in your body, but the cortisol decrease the protein in our body. That is how the cortisol work in our body. Increase the fats, decrease the protein, and cortisol affect the calcium level. Cortisol affects sodium level. Cortisol affects the potassium level. So it has many effects on our body. So let's imagine patient with Cushing syndrome. Cushing syndrome, there is high cortisol. So all these functions will be exaggerated because it is abnormal high cortisol. So if there is abnormal high cortisol, there will be high glucose level, hyperglycemia, high blood pressure level, hypertension, hypernatremia, because high sodium also happen with the high blood pressure, then low potassium, low calcium, low potassium, low calcium. So I will say high sugar, high salt, and the high pressure. So the cortisol cause high sugar, high salt, high blood pressure, low potassium, low calcium. Since the cortisol increase the fat in the body, the fat will deposit in areas in the body. So Cushing syndrome will have moon face, more fats. They will have buffalo hump. The fats will be there. They will have obesity in the trunk, truncal obesity. Yeah? More fats will cause acne. They will have more acne. A lot of steroid destroy the protein. If it is very high steroid level, very high steroid, that's not good for the protein. So the protein will decrease. So they will have wasting extremities. Their extremities, their upper limb, their lower limb will be very thin. So they will have big trunk and thin extremities. Also, the protein forming the skin will decrease. So the patient will have stretch marks. Look at the stretch marks here, abdominal stretch marks. We call them stria, abdominal stria. This is Cushing syndrome. Yeah. So this is how the steroid affects the body, and this is how the Cushing syndrome present. Now Addison is low cortisol, guys. Addison will be opposite to whatever we found here. Tell me, in Addison, what will happen to the blood sugar, high or low? Addison,
Low.
low. What will happen to the sodium, high or low?
Low.
Sodium, low.
Low.
And the blood pressure also, high or low?
Low.
Low.
Low. And then what about potassium and the calcium? Potassium and the calcium, they will go high because this is opposite to Cushing. If there is low blood pressure here, this patient need to be very careful when they change a position. They should avoid changing their position, or they change their position slowly. Yeah, their body will be weak because of the low blood pressure. They have weakness. They will have bronze color skin. Very characteristic of Addison, bronze colored skin. For some reason, NCLEX like the bronze color skin in Addison. Many students, they come, oh, we got bronze color skin. One of the questions, like one of the select all that apply in the finding of Addison. So this is Cushing versus Addison. Okay, since Addison, they have low cortisol. So how we treat it, guys? Low cortisol in Addison, how we treat this disease?
You would give cortisol?
Give cortisol. So Addison treatment is give steroids, give cortisol. What about Cushing? Their adrenal gland producing high cortisol. So how we treat this? What do you think? How we treat this? Let's remove the gland. Let's remove the adrenal gland. So this is adrenalectomy. Adrenalectomy.
High protein.
Adrenalectomy, and give diet high in protein. That's a good one. Yes. Good job. What about the diet for Addison disease, guys?
High calcium, high protein.
Okay. Okay. Let me give you a memory trick. Addison. Look how I'm going to write something here. Add Addison, right? Add salt. Add salt. So for Addison, guys, you need to give high sodium diet because they have hyponatremia. Hyponatremia. So give high sodium, low potassium diet. High sodium, low potassium diet for Addison. Addison. Add sodium, low potassium.
Got it.
Yeah. Memory sugars are very helpful. So try to use your memory sugars. Yeah. And last one is pheochromocytoma. Pheochromocytoma. What is this? This is increase in the adrenaline produced from adrenal gland. It's also adrenal gland problem, but not cortisol. It's problem in the adrenal medulla, which produce catecholamines or the adrenalins. So there is adrenaline produced from the adrenal gland. And what adrenaline does, guys, to the body? What adrenaline does? This is your...
Increases our fight or flight.
Good job, Maria. Fight or flight. So the patient will have this high adrenaline gush in their body, so they will get fight or flight symptoms, which is what will happen to their heart rate.
Increase.
Increase. What will happen to the blood pressure?
Increase.
Increase. So the patient with pheochromocytoma, they will get attacks of 5 H's, which is hypertension, hypermetabolism, because the fight or flight make him like hot, burn, hyperhidrosis, which is sweating, hyperglycemia. They might get headaches also because of the high blood pressure, and blurry vision. They will be agitated. This is fight or flight. So if you have your patient presenting with these symptoms, hypertension, hyperglycemia, hyperhidrosis, sweating, agitation, headaches, that could be pheochromocytoma, which is tumor in the adrenal medulla produce adrenaline. Since it is tumor, we need to remove this surgically. Treatment is adrenalectomy. Yes? And how the nurse expect what the doctor will order to diagnose this disease. It is imaging like CT or MRI to see the tumor, and then they will do surgical removal. Yeah? So this is the last one of the endocrine. So this is done with endocrine. We got the thyroid problems, hyper versus hypo. We got the parathyroid gland problems, hyper versus hypo. We got the antidiuretic hormone problem, which is diabetes insipidus versus SIADH. We got Cushing versus Addison, and the last one is pheochromocytoma. This is your endocrine, guys. Yeah? Plus the big one, which is diabetes mellitus, which, like, you know it all. I will not review diabetes mellitus, diabetic ketoacidosis, very important, very high yield, and I know you all know this. Insulin. Who remember how to mix insulin? What is the mnemonic we learned it? How to mix insulin. You have regular and you have NPH. How you mix them?
Is it clear to cloudy?
Okay, clear to cloudy. Which one is clear? Which one is cloudy?
Insulin clear.
There is regular, there is NPH, right? So which one is clear? Which one is cloudy?
Regular insulin is clear.
The regular insulin is clear, yes. Yes, that is right. Regular insulin is clear, and the other one is cloudy. Okay, so if you have two vials, one is regular, one is NPH, what are the steps to withdraw and mix insulin? Who will take care of this? Who will give me the Nicole Richie RN?
Let's see.
Huh? Did you guys, if you're tired, we can like end the meeting today, because I know this is the end of the day. There's no problem at all. But let's finish this slide and then let's decide about the how
So-
more we can get.
You clean the vial with alcohol for like 10 seconds.
Okay.
You aspirate. So if it's like 15 units of insulin, you would aspirate 15 units of air into the vial.
You
pull up-
aspirate or you inject?
Or sorry, you inject the air into the vial.
Okay, which
then-
vial you inject air in first?
The insulin.
Which insulin, regular or NPH?
Regular.
Okay.
And then you remove the designated amount. So 10 units, you would remove 10 units. And then you put the needle into the cloudy and pull out the desired amount, right?
Okay.
I've never had to
And-
mix insulin. I've just like used regular insulin or the insulin pens.
Okay. Yes, that is good. I know, but this is a very high yield question here, guys. Let's focus together on how to mix insulin. But good job, Roxy. How to mix insulin? You have two vials. One is NPH, one is regular, right? You want to withdraw. There is prescription, 30 units NPH, and there is 12 units regular. This is a prescription. So as Roxy said, you inject air equal to the same amount of the prescribed insulin. So if there's NPH, 30 units, so you inject 30 units air in the NPH first, then inject 12 units air in the regular, then you withdraw from regular, then you withdraw from NPH. So it is N, R, R, N. NPH, inject air first. Regular, inject air. Then withdraw from regular. withdraw from NPH. NRRN. I go with Nicole Ricci RN, which is NRRN. Inject air first in the NPH, then inject air in the regular, then withdraw from regular, then withdraw from NPH. Yeah?
Mhm.
We know how to do this sometimes, but when you get to see the wording and the steps, when they say put the steps in order, sometimes we get confused. So learn it this way. Nicole Ricci RN, NRRN. Inject air first in the NPH, then inject air in regular, withdraw from regular, withdraw from NPH. Yeah? Okay, guys. So this is our endocrine, and you have them in the same order in the packet I gave you. Make sure you read them, review them. When you get questions on them, go look at the packet, add notes to this packet to build. So our steps, upcoming steps to prepare for our exam, you have the notes and you will work on questions. Questions every day. Take an exam. Take an exam, you might finish the exam in 2 to 3 hours. Please don't finish studying the exam in 30 minutes. You need 2 to 3 hours to study the exam. Read every single explanation, put notes maybe in the packet I gave you. Build your key study guide. Put your packet up, Roxy. This is a packet, guys, everyone received. Yes? Or if you have another one, stick with the one you have. But the main reason is you need a summary. You need something to go, something fast, because there is no time to, we're not repeating nursing school here. We're just hitting the high yield topics. So you will take an exam, at least 4 exams a week. I will not say 7 exams a week. No, 4 exams a week. And divide your day AM, PM. Take exam in the morning, study it in the evening, or opposite. Take notes. Study the exam well before you take next. With each exam you take, you look at low score area, create exam on it for next time. Yeah? And by now, everyone already decided about the resource you will use. And I'll see you tomorrow, guys, at 10 o'clock. As planned, I know not everyone is coming. And good luck for everyone's plan. I know. So good luck. I'll see you next week if you're not coming tomorrow, but tomorrow will be at 10 o'clock. We will have our either predictor or exit or diagnostic. After tomorrow, we will have one-on-one. I will have one-on-one with whoever take the diagnostic to put a study plan for you. I will let you know once the school sends your RONP to start your application. I believe we're very saturated. That is heavy, and it is the end of the day. So I will stop here. What do you think, guys? You know what you need to study? You know your steps?
Are you still, so we're not gonna have another one to do renal and mental health and pharmacology?
If you guys want, I can do that. If you want. Renal, mental health form. If you want, text me as a group. If not, I can visit these with one-on-one. Easy.
That'd
Drea,
be great for me
okay.
Yeah.
So yeah,
because I'm busy
let's
tomorrow.
not tomorrow. You're not in the group, Drea. I will send you the link, Drea. So we can have another one for kidney, for mental health, for farm. Yes, okay. So let's do one. Mostly it will be next Thursday.
Okay.
Okay, guys, I'll see you tomorrow at 10 o'clock, and I will send you the schedule for next week. Sure, I will be happy to do that.
Thank
So
you,
I will send you the link, whoever is not in the group. You're very welcome.
Thank you.
I'll
You're
do my
welcome.
diagnostic next week, Dr. Mano.
Brett